Okay, everybody, my name is Alex Hughes, and it's a little bit past 6. I'm going to go ahead and get started with the webinar. I am the lead nurse practitioner for the practice. This is Dr. Shaw's practice, Austin Urology Institute. And I decided to do a webinar. This is one of the most not really talked about topics, but it's a very common urological problem that we see. I signed up probably 3 different people for some kidney stone surgeries today. So it's one of the biggest urological issues out there, and one of the biggest reasons people come to see a urologist. So this is kidney stones evaluation, prevention, and the modern management, presented by me, the lead APP, Alex Hughes. So my goal here is to educate and empower patients by explaining why kidney stones form and how they can be treated, and most importantly, how to prevent them from happening. Because if they happen, and you form a kidney stone and it becomes an obstructed pathology or an obstructed problem, then you're looking at you have to do surgery. There's not really any other kind of methods out there. So it's one of the biggest common reasons of an OR visit is kidney stone surgeries. And I'll go through a lot of those different types of surgeries out there. But it's one very, very common thing, and it can be prevented. A lot of them can be prevented. So what are kidney stones? So we're gonna go over the different types, how and why they form and who's at risk. How do we treat them? So the medications, procedures, surgical options, what to expect during those treatments, and how we can prevent those kidney stones. Lifestyle changes and diet, medications and supplements, and long-term strategies to reduce recurrences. So the different types of kidney stones. This is one of the most common, you know, confusion topics of my patients. They don't realize that there's different types of kidney stones. Like I had a patient today that was passing up debris of her kidney stones because we had shocked it. And I was like, did you bring some to get it analyzed? And she was like, well, why would I get it analyzed? I'm like, well, if we know what kind of stone you make, then we can give you different treatment options or different prevention methods, because not all stones are made the same. So the most common type of kidney stones are calcium oxalate kidney stones. Around 70 to 80% of kidney stones are calcium oxalates, often linked to high oxalates, so spinach, nuts, chocolates, or low fluid intake. The next step below that are calcium phosphate stones associated with high urine pH. Can occur with metabolic conditions, renal tubular acidosis. So these are very complex nephrology type issues. Uric acid kidney stones linked to gout, high purine diets like red meat and shellfish. And they form an acidic urine. And struvite stones, these are infected stones caused by urease producing bacteria, can grow quickly into a staghorn calculi. So staghorn calculi are forming now the calyxes of the kidney. So the kidney has different little, almost like caverns. They're called calyxes, and they can form into that whole calyx and then kind of disrupt kidney function. And cystine stones, rare. These are used to genetic disorders. Cystinuria tend to reoccur and require special management. So those are the 5 different types of kidney stones out there. So calcium oxalate kidney stones, we'll talk about the most common type first. The risk are low fluid intake, high oxalate diets, spinach, nuts, chocolate, tea. Diet tea and sweet tea have very high oxalate contents, high sodium intake, obesity, and metabolic syndrome. So because these are the most common type of kidney stones, kind of whenever you think about kidney stones and what you should avoid, usually people are thinking about calcium oxalate kidney stones. So when I have a patient that comes in that's, overweight, has diet primarily used from like fast food restaurants, which are very high sodium diets, more than likely calcium oxalate kidney stones. And on the contrary, I will have patients that come in that are extremely fit, and they are making kidney stones. And then think about being extremely fit. What are you doing? You're working out a ton, so you're losing fluids different ways, right? So if you're a marathon runner or you go to the gym or you do hot yoga, you're losing all of your fluids in sweat and not from the right way where it's coming down. And a lot of times, those very athletic people or the healthy people have very high rich diets. So what is that? Spinach, kale, almonds, peanut butter. All of these foods that we're taught are very, very high in nutrient dense, which they are. But if you have everything, or if you have, things every day, if you have a spinach and kale smoothie every day, then yeah, your oxalate content can be very high. And if you're working out, you have a fluid disruption, you're kind of being set up to make a kidney stone. So how do we see these? These are radiopaque on X-ray and CT scan. I'm going to say those words a lot. So that means it'll show up on an X-ray. It'll show up on a CT scan. So different stones are visualized different ways. Treatment, medical expulsive therapy. So you just try to pass the stone on your own using tamsulosin. So this is a medication primarily used for BPH, so an enlarged prostate gland. So it widens the prostatic urethra, but it also widens the ureters. So what happens with kidney stones, you got your kidney beans here, right? They're kind of off-centered. You have your ureters coming down into the bladder. Those stones can get stuck into those ureters. That's what we call obstructing kidney stones. And if you use tamsulosin, it widens that ureter and makes sure that stone can pass safely and not cause you too much pain. But what you also have to do is you have to increase your fluids. Water is what I primarily mean. So you want to increase your waters to put the fluids on top of the stone. You widen that ureter with the tamsulosin, and then you can actually medically expulse that kidney stone. Shockwave lithotripsy, ureteroscopy, prevention with like thiazides can help with that, and potassium citrate, and dietary recommendations. So all those are prevention and treatment methods. Calcium phosphate stones. So I have my graph here, so it shows the percentages of likelihood of stones. So you can see calcium oxalate, overpowers all of these, 70%. Uric acid and calcium phosphate are around 10%. So that leaves 10% for struvite and cystine stones. So those are super rare. So calcium phosphate is a very common kidney stone. And a lot of time, whenever I do a stone analysis, sometimes it'll be like 20% calcium phosphate and the rest calcium oxalate. So you can actually have stones intermixed with byproducts and intermixed with properties. And then you kind of have to do recommendations for both of those types of stones. So calcium phosphate stones are the second most common type, form an alkaline urine. So risk of renal tubular acidosis, hyperparathyroidism, so the thyroid gland, heart-shaped gland here, and then you have your thyroid, or sorry, your parathyroid, which are four little nodules on the outside. So if you have like a lesion on there or some kind of other kind of ailment that causes your parathyroid to be hyper stimulated, you can have these kinds of stones. High urinary pH and medications. Topiramate, which is for headaches, is very, very common in making calcium phosphate stones. So moderate your calcium, reduce your sodium, limit alkaline foods, and medications that raise the pH. This is all about balance. You'll see that as I kind of go through this webinar. It's all about balancing, your metabolic profile. And it's really interesting when I first got into urology and I started seeing a 24-hour urine collection, which I'll talk to y'all later about. I have a pool in my backyard and I have to actually regulate the pH and I have to regulate the calcium. I have to regulate that. And so I was actually equating, kind of getting the actual levels in my pool. That's exactly what we're doing in the body when it comes to kidney stones. So like even in my pool, I'll have some calcium byproducts start to collect around my pool edge, and I know that my calcium is too high in the pool, and then I need to offset that with like muriatic acid or some of the other pH, balancers that are out there. So these are radiopaque on X-ray and CT scan, just like calcium oxalate kidney stones. And then you treat the underlying cause. So if you have renal tubular acidosis, you can correct that with certain, medications and things of that nature. And then you can use thiazides or potassium citrate, cautiously, because you don't want to increase your potassium levels too much as well, too. So you need to regulate that and, have primary care or a urologist look at your potassium levels. Uric acid kidney stones. These are stones formed from the uric acid crystallization in the acidic urine. Gout, obesity, diabetes, high purine diet. So red meat, shellfish, organ meats. So I am a big proponent on the carnivore diet, but too much red meat can have you set up for uric acid disorders, which could lead to uric acid kidney stones. So if you have uric acid kidney stones, and we will do that under an analysis, so you'll pass a stone, or we'll break up the stone, we'll send it for an analysis. A low purine diet, reduce animal protein, increase your fluids, and alkalize your urine. So you can do that with either urine citrate or bicarbonate. How do you see these? These are radiolucent on X-ray, so they're not visible, and they're only seen on CT scan or ultrasound. So one of the imaging modalities that I utilize all the time for surveillance is something called a KUB, kidney, ureter, bladder. The other term for it is an abdomen 2 view. So basically an abdomen x-ray on both sides. So you do it on the coronal and then the sagittal view. But if I was monitoring a patient for uric acid kidney stones, I wouldn't be doing a KUB because you don't see them under the KUB. So you have to do a CT scan or a renal ultrasound. Treatment, potassium citrate to raise the urine pH, allopurinol if hyperuricemia, and surgery if needed. So I will check your uric acid levels. So like my big questions whenever I'm doing a kidney stone evaluation, especially if I know they have uric acid kidney stones, are do you have gout? Have you ever had, a big toe that's swollen or your joints that hurt? And I can check a serum uric acid level and actually check that in their blood. Struvite stones. So again, these are the almost the fourth most common, or least common, I guess I should say. These are infection stones. These are composed of magnesium and ammonium phosphate. So again, on your 24-hour urine, and I'm going to talk a lot about that later, it looks at your magnesium levels, it looks at your ammonium levels, it looks at your phosphate levels. So chronic urinary tract infections can set you up for this. So Proteus, Klebsiella, Pseudomonas UTIs will really set up for struvite stones. No major dietary factors. It's driven by infection only. So focus on preventing whatever's causing the UTIs. These are very large kidney stones. They're staghorn calculi. I talked a little bit about that earlier. So these staghorn calculi will literally form in all these calyxes, and it looks very, very, very big on either CT or X-ray. Surgical removal, often percutaneous nephrolithotomy. So this is a surgical procedure that we actually don't really do in our practice. But I'll go into it later. I'll talk about all the surgery treatments, but that's what you'd have to do for these big O kidney stones. Antibiotics, so you can try to treat the infection process and then manage recurrent infections. Cystine stones, these are rare. They're hereditary, so cystine urea. Stones are in the cystine in the urine, so there's a genetic mutation. Again, very, very rare. I think I may have found one or two in my career so far. So this is from impaired cystine reabsorption. So strong family history. If they have, oh, my mother's fathers, grandfathers, they've all made kidney stones all their life. They may make cystine stones. Very high fluid intake. So you want to wash out the cystine, alkalizing in the urine, restrict sodium and animal protein. They are faintly radiopaque, so they can see subtly on an X-ray, but best seen on CT scan. You can kind of see a pattern here. Almost all of the stones are seen on CT scan the most. So the form that I utilize in my practice a lot with looking for kidney stones are CT scans because they look for everything. But CT scans have the highest radiation exposure. So you really try to mitigate risk to the patient versus the right kind of imaging order. So a KUB, which is only 2 X-rays, a CT scan is hundreds of X-rays or 100 X-rays. So you try to do the least, harm to the patient by managing. That's why we don't do CT scans constantly with patients. I don't want to, do a CT scan every 3 months. That's too much radiation exposure to the patient. Treatment, urinary alkalization, binding drugs, troponin, tiopronin, and surgery often required. So treatment. So we figured out what kidney stone you have. How do we treat these things? Medications help stones pass or reduce reoccurrences. Minimally invasive procedures break up the stones without large incisions. Surgical options remove larger or complex stones. The goal is to relieve pain, clear the stones, and prevent reoccurrences. So these 4 pictures kind of give an overview of the all of the different treatment options. So medical expulsion therapy, ESWAL, that's shockwave lithotripsy, ureteroscopy with a stent, and then the percutaneous nephrolithotomy. So medical expulsion therapy, you give patients meds to make the stones come out. So medications to help small stones 5 to 7 millimeters pass naturally. Alpha blockers, tamsulosin, and NSAIDs for pain. Avoid surgery, often effective for small distal, so the bottom. So basically, if you have your kidneys here, so what this picture I'm looking at is proximal. So this is closer to the kidney. Distal is away from the organ system. So if you have a distal stone, meaning the stone has made it all the way to the bottom of the ureter, a lot of times you could use medical expulsion therapy for that because the stone is already passed all the way down to the ureter. Um, so may take days or weeks. Monitor for fever, uncontrolled pain, or obstruction. So the bummer about this method of treating the kidney stones is unless the stone passes and the patient says, "Hey, I peed out a stone," then you have to assume that stone is always there. So you have to repeat the image. And this means, every 2 to 3 weeks, you may be doing a CT scan and watching that stone slowly progress. And they're hurting during this whole time, and they're set up for really bad infections. So, extracorporeal shockwave lithotripsy, ESWAL for short. This uses sound waves to break up stones. These are stones less than 2 centimeters, usually softer stones, so Hounsfield's units. This is how I measure how dense a stone is. So, we have programs on our PAX system where I can hover over the stone and it'll give me the density of the stone. So if the stone is around 500 to 1100 Hounsfield units, it means it would be a good candidate for shockwave lithotripsy, meaning it's dense enough for you to see the stone. It's soft enough for the stone to break up. Non-obstructed below the pelvic brim. So your pelvis, we all know what our pelvis is. It hides the ureter. So those distal stones that I was talking about, if it's underneath the pelvic brim, you can't shock those stones because you can't shock through bone. So that may you either have to medically expulse that one, so you take your tamsulosin and try to get the stone out, and if you can't pass it that way, we're going to go up into the ureter, which is the next surgery. Usually sedation or light anesthesia. Bruising, hematuria, need to strain urine for fragments, may require repeat sessions. So the bummer about the ESWAL, and I said, the bigger the stone is, the denser the stone is, you may require 2 or 3 ESWALs on these stones. So this is a patient coming back for more anesthesia, blah, blah, blah. And you do have to pass all the stone fragments. So if you have a good 8 millimeter stone sitting in the kidney and you shock it and you break it up to 2 4s, then you got to pass those 2 4s through the ureter. Ureteroscopies with a stent, what we say is a URS with a stent. So tiny camera passes into the ureter bladder, uses a laser to blast the stone, and then you can basket and retrieve those stones with the same kind of equipment. So here on this picture, you can see this is the actual scope going into the kidney. And so if there's a little stone here, we would use a laser to break it up. You can use fluid to irrigate that out, or even a basket to remove the stone from the kidney. This is the method that you would do if the kidney stone is lodged in the ureter. So if it's in the ureter and causing obstruction, which means a backflow into the kidney, and that's called hydronephrosis. So if the kidney is plugged up like a clogged toilet, then the kidney will have a backflow of urine, and that's where this acute pain is having. So a lot of patients will come in for back pain and they will have a non-obstructing stone, meaning the stone is just sitting in the kidney. That stone is not causing your pain. Whenever you have pain from kidney stones, it's whenever it's lodged in the ureter. The ureter acts like have you ever seen a snake eat, where a snake will actually kind of churn its food or push its food down? It's called peristalsis. So the ureter will actually use peristalsis to try to move that kidney stone down. But when it gets to that kidney, it scratches it and squeezes it, and that's where that pain. So that's often why kidney stones come in waves of pain, because that peristalsis is going down the ureter. So as soon as it crosses over the stone, it squeezes it. You have terrible, terrible pain, and then it passes. Then it does it again, squeezes, squeezes, tries to pass it. So it's trying to push that stone down with the peristalsis. So stones in the ureter or in the kidney not suited for ESWAL so a stent. So a lot of patients don't realize what a stent is. A stent is a plastic tube, the size of like the end part of, sorry, the middle part of a pen. You know, like the where that holds the ink. So that's what about the width of a stent, and it's this long plastic tube. So anytime you go into the ureter with a ureteroscope, you run the risk of that ureter basically running into renal colic or stricturing down. So you leave a stent in place to keep all of the debris, and if they have swelling from the kidneys, all of the pus, all of that stuff to safely travel through the stent and into the bladder. So when we go into the kidney and we use the laser, we break up the stone into tiny fragments, and then we leave that stent in place for all those fragments to pass. Temporary stent discomfort, urgency, frequency, flank pains. I tell my patients all the time, people hate the stent more so than the stone. So I just warn my patients, you're going to be uncomfortable. It's a nature of the beast. We can give you medications, but the stent is literally causing the discomfort. There's not much else you can do. Now, what I will say is you can use like a heating pad to that area to really help with it. There are some medicines we can give, but honestly, the stent just hurts. So the PCNL or the PERC tube, this is percutaneous nephrolithotomy. This is for really big kidney stones. And basically they put a hole directly into the kidney from the back. This is done in the hospital. So a small incision into the back, direct access to the kidney to remove very large stones, stones that are bigger than 2 centimeters, so about an inch big, staghorn calculi, dense stones. Hospital stay, typically 1 to 2 nights. A tube temporarily drains the kidney, higher success rate for a complete stone clearance. So if you have just giant stones or multiple stones throughout the kidney, or the staghorn calculi, percutaneous nephrolithotomy is a good choice. Again, we just don't do that here in our office. So prevention overview. So you've had your treatment, you've done the surgery, we found the stone with a CT scan. We haven't figured out what it is yet. So that is one thing. So after you have the surgery, if we do the ESWAL, then you're going to, collect fragments into a cup, and then you're going to send them off to your appointment. Or if we go and do a URS, we can actually take some of those stone fragments and send it to the lab to be analyzed. So lifestyle changes in diet, cornerstone of prevention. This is usually a dietary problem. Medication, so this will be tailored to your urine chemistry, long-term monitoring, and then our approach, individualized prevention plan based on 24-hour urine and metabolic labs. So I kind of say that my patients go into a kidney stone maintenance program where every year I'm going to do an image and a 24-hour urine collection. And a lot of times I kind of equate that to if you have ever started to go to the gym and you've hired a trainer, and that trainer is there to motivate you and to keep you on track. That 24-hour urine and those images are to keep you on track. So what are like the most common lifestyle and dietary changes? Aim for 2.5 to 3 liters of fluid a day. I always say the answer to the pollution is dilution. So the bigger your ureters, the more fluid passing through those kidneys, the harder it is for stones to form. Keep dietary sodium less than 2,300 milligrams per day. Too much salt increases urine calcium. Moderate animal protein, excess uric acid lowers urine citrate. Calcium, normal dietary calcium. So this is one of the most common misconceptions. And I will be very honest, I used to teach this incorrectly. I used to tell patients, get that calcium out of your diet because of calcium, oxalate kidney stones, calcium phosphate kidney stones. It makes just complete sense to me that you would decrease your dietary calcium. I was actually probably doing some harm to the patients, because if you actually have higher levels of calcium in your food, they attract the oxalates in the stomach and it comes out with the stool. Reduce high oxalate foods. So high oxalate, spinach, nuts, chocolate, kale, soy products, tea. Those are all very high oxalate foods. And if you limit those, it'll decrease your risk of calcium oxalate kidney stones. Citrate. So increasing the citrate. So the way that I teach this is if you have high levels of citrate in your urine, it'll make calcium and oxalate ions to where they will not connect. So I often say, like, if you have two magnets putting together and they kind of forced away from each other, y'all have all done that with like the two positive sides. That's what citrate does. So lemon, lime, citrate, high levels of fruit will help increase these levels and keep those calcium oxalate ions away from each other. Obesity and metabolic syndrome. So metabolic syndrome is a couple of labs kind of looking at your blood sugar and your lipid panel and things of that nature. Obesity, there's a direct link in obesity and kidney stones. So medications and supplements, thiazide diuretics. So this is hydrochlorothiazide. It lowers the urine calcium for calcium oxalate stones, or sorry, calcium stones. Potassium citrate, it alkalizes urine, increases citrate, prevents calcium oxalate and uric acid kidney stones. Allopurinol for hyperuricosuriasia or gout. That's a hard word to say. So high levels of uric acid. Cysteine binding agents for rare cystinuria cases, and supplements. So citrate tablets, KSP tabs, that's what we utilize in our clinic a lot. These are like little Alka-Seltzers you put into your drink, and they can, increase your water output. It'll decrease your oxalate content. It kind of increases your citrate levels. It does everything that you're supposed to do to help prevent stones. Theralogics formulation. So Theralogics is a supplement company that we utilize a lot. They have Theralift and Citralift. So these are all things that kind of help all of those metrics to help prevent those kidney stones. Long-term monitoring. So again, once you become a kidney stone patient of ours and we've treated you and we've done a baseline imaging, yearly imaging, KUB, X-ray, or a renal ultrasound to track stone burden. So and we don't typically monitor with a CT scan. It'll either be an X-ray or a renal ultrasound. So the reason for that, if you do a yearly X-ray, what you're looking for is you're trying to catch the stones in the kidney so that you can shock it. And if you can see it on X-ray, you can see it in the operating room at shockwave lithotripsy. So the whole point of and I always say this to my patients, the whole point is to prevent stones from happening completely. But if you're gonna make a kidney stone, you want to make it in the kidney. That way you can shock it and then pass the debris. Yearly 24-hour urine testing guides diet, medication changes, calcium oxalate, citrate, uric acid, sodium, volume, all of the stuff that you're looking for on why you made a kidney stone. And again, this is kind of like your spotter in the gym. You want to keep yourself on track. I've had a lot of patients that said the whole reason they even keep track with their urine volume is by these yearly 24-hour urines. Metabolic lab. So again, part of my initial evaluation, if I don't have your stone, I'm going to check your parathyroid. It checks for hyperparathyroidism. I'm going to check your serum calcium. I'm going to check your uric acid. And I'm going to couple all those things with a 24-hour urine collection to try to figure out which stone you're actually making. Yearly office visits if you're stable. Prevention plans sooner if new stones form. So the prevention mindset. So again, kidney stones can be prevented. So there are some that are hereditary out there, but they're chronic and they're not one-time events. The prevention, hydration, plus diet, plus tailored meds and monitoring. That is the way to prevent yourself from becoming an emergency. So the whole point is to try to make sure that the kidney stones do not get into the ureter and cause damage. Because a lot of my guys and girls, but it's mainly guys, will say, oh man, I passed that 10 millimeter stone, no problem. Every time you're passing stones through the ureters, that causes damage to the ureter. So and when you have damage to the ureters, you run the risk of stricture disease. So every time you're passing those stones, it's creating damage to the ureters. And I've had patients that have been passing kidney stones years and years and years. Those ureters get smaller and smaller and smaller. And then you're set up for even more kidney stones to actually come down that pipe and get stuck. So the whole point is to prevent stones from happening completely. But if you're going to get a kidney stone, you want it stuck in the kidney. That way you can shock it from above and pass the debris. So that's the whole point of it. Goal is to reduce stones reoccurrences, avoid surgery, and preserve long-term kidney function. Because every time you have swelling into that kidney, it's going to cause damage to that kidney, and damage to yourself. I've had patients that have had chronic kidney disease from kidney stones. So the whole point is really to prevent those stones from happening. So that was the quick overview. It went a little bit over 30 minutes. I will stay around for any Q&A about kidney stones. I have one question kind of loaded up here. If the kidney stones stay in the kidneys and are not causing problems, at what point do these need to be removed? Good question. So, if they are staying in the kidneys and they are less than 5 millimeters, we can monitor those. So, the ureter that comes out of the kidney. So, you got your kidney bean, right? So, you got, I can't do my hand. And then you have your ureter coming out. This junction is 5 millimeters. So, if it's smaller than that, because a lot of times I'll do a CT scan. Hold on, let me click that. A CT scan, and you'll see something called punctate stones, which are basically salt and pepper in the kidney, and they can be like 1 millimeters, 2 millimeters, 3 millimeters. I would never do surgery on those. I would never have my patients go and do a shockwave lithotripsy on that. So those stones can be passed. So if those stones are nice and small, we can monitor them, and then you can, increase your fluid and all those kinds of things to make sure that they pass safely. The stones that you will shock are stones that are 5 millimeters or larger, or if you can see them on X-ray. Yes, ma'am. I can get you a copy of this. What we will do is I'll have it available on YouTube. So our YouTube channel is austinurologyinstitute.com, or I don't know if it's .com, but it's Austin Urology Institute, and it'll be available on there so anyone can actually view it at any time. Well, I'd really appreciate y'all coming on here and listening to me. Kidney stones are one of those things that can be prevented, and they are a bugger to deal with. So again, this will be available on our YouTube channel. And if you have any other questions, message me on your portals. I know most of y'all are patients of mine, so if y'all have any questions or anything that I spoke about tonight, just message me. But I really appreciate y'all joining tonight, and have a good evening.